Hello, and welcome to the University of Washington Cardiometabolic Echo Session 7. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington Diabetes Institute. Today, we're really excited to have our session about sodium glucose transporter inhibitors, and we're going to have it duped out by our cardiologist, who is Dr. Kelly Branch, and our nephrologist, who is Dr. Nayan Arora, and they're going to be sort of doing the yin and yang of sodium glucose cotransporter inhibitors from a cardiac and renal perspective. And as well, we're going to have a great case by Annika Barnett, and she's going to be presenting a great case for diabetes in someone who has worsening control and really isn't interested in injectable medications. And now I'm going to go ahead and have Dr. Kelly Branch go ahead and introduce yourself.
Great. Thank you so much, and so happy to be here. So I'm Kelly Branch. I'm a professor at the University of Washington, and indeed am a cardiologist. But I'm thrilled to have Dr. Arora as a nephrologist. I'd like to say we actually work pretty well together most of the time as we're sharing patients. It's been a while since Nayan tried to choke me out, but he ended up being right about that patient anyway. But I'm really happy to be here.
Nayan Arora, do you want to go ahead and introduce yourself briefly?
Yeah, hey everybody. I am a associate professor at Oregon Health and Science University in Portland, where I am a nephrologist. I did spend a fair amount of time at UW. Part of that was on our cardiorenal service, as well as staffing the diabetic kidney disease clinic. And so I was happy to get the invitation again to be here to talk about SGLT2 inhibitors. Like, Dr. Branch said, I think these memes of cardiology versus nephrology are no longer accurate with a lot of these medications that really blur both lines, and hopefully we'll share a little bit about that today.
Great, thank you, Nayan. And then Dr. Laura Montour, will you mind introducing yourself?
Hi, everyone. It's good to be back. I was here obviously a couple of weeks ago, but I'm the co-director for the Center for Weight Loss and Metabolic Surgery at UW, and I'm also a family physician.
Thank you, Laura. And I don't believe Savitha Subramanian, one of our adult endocrinologists and lipid experts, is on yet, but we all know how clinic is, and so she'll be joining us. So now, Kelly, go ahead, take it away and start lecture 7.
Wonderful. So obviously we're going to be talking about SGLT2 inhibitors. The objectives are that we are going to be describing some of these in terms of mechanism of action, efficacy, side effects, and I'm going to really focusing on a cardiovascular and then a little bit less on the renal disease benefit. And then Nayan will be talking about the kind of the liver and NASH as well. We'll talk a little bit about the side effect profile and risk, but really more specifically, how do we translate these very effective medications into our patients with renal disease, heart failure, or cardiovascular disease, or many times the combination of those things, because they can be isolated, but generally they tend to cluster if 1 to 3 of those. Here are some of the disclosures that we have. The only ones that are salient were that I was actually on the executive committee for the Rewind trial as well as the Amplitude O trial. And then Dr. Arora is there for speakers bureaus for Bayer and AstraZeneca. So I think a lot of people know, but just to kind of reiterate, just to bring us up to speed, cardiovascular complications are the main cause for mortality in diabetes, and in many cases, one of the major causes for morbidity as well, because those patients with microvascular complications are more likely to have a cardiovascular event, right? And whether or not it is brain, heart, or peripheral arterial disease or peripheral vascular disease, depending on how you like to say it, we do know that the brain is effective because there's a lot more stroke that can occur. And for every 1% increase in the A1C, stroke goes up by about 30%, so about a third higher, right? What about heart? Well, for cardiovascular events, and this can be coronary disease, this can be other vascular issues, and heart failure, 2/3 of the deaths in type 2 diabetes are attributable to cardiovascular disease. And if you look at mortality, there's a 2 to 6 times higher risk of mortality from cardiovascular events in diabetics. And then, of course, heart failure, whether or not it's from myocardial infarction or due to diabetes itself, 2.5 risk. And then peripheral arterial disease, which is really the worst kind of disease you can have, puts you at the highest risk, and especially if you have polyvascular disease, highest risk of having cardiovascular events. These are really problems. And a lot of that has to be with, low-grade inflammation, accelerated atherosclerosis. So we've seen all that. So with that in mind, where do SGLT2s kind of come in? Well, we talked about what's currently available. Unfortunately, over time, we now have multiple SGLT2s that are available. You can see those over to the left-hand side. We have some of those that are under development. We do have one that's an SGLT2 and SGLT1 combo, but we use a lot of these medications both in cardiology as well as nephrology. And it's almost to the point where, sure, the endocrinologists have it, but it feels like cardiology kind of owns it, and especially because it's simple, and cardiologists love to hit the simple button and make it easy in order so that we can give a medication we're comfortable with, and because we are risk averse in order to cause hypoglycemia. We hate that. But how does it work? And then how could this potentially benefit from a cardiovascular disease endpoint? So it blocks that SGLT2 transporter, which is really where most of the glucose reabsorption occurs, and Nyan's going to talk more about this. But really what it is glycosuria, right? So it was the way that we used to test for diabetes, and if you were my grandfather, you actually had to dip your finger into the urine and taste it and see whether or not it was, he'd love to tell me that story. But that's how you test for diabetes, was for glycosuria. Well, now we're doing it in an artificial way by actually using SGLT2s. And the more hyperglycemia you have, the more you're going to spill glucose, right? But because this is an independent of insulin, then the risk of hyperglycemia is actually much lower. It really is only increased when we have some other concomitant medication. And I'll leave it to the endocrinologist to say any more, otherwise I will probably get in trouble. But if you look at the issues as far as cardioprotection goes, what does it do? Well, it does a number of things, right? One of the things is it can decrease preload, right? Because you're having glycosuria, so you are having a diuresis along with it. So it can also increase afterload a little bit through the central venous pressure. So it just kind of lowers everything a little bit. But it does have this anti-inflammatory, that kind of ratio between anti and pro-inflammatory, kind of that ratio, the cytokines. So you can see some benefit in that way. We also see that potentially it could be reduced cardiac fibrosis, which is kind of an interesting thing for us, especially when we're talking about heart failure, and heart failure preserved ejection fraction even more. And then we see some other things as far as improved hematocrit, as well as some improvements in cardiometabolic efficiency. We won't go into that, but very interesting basic science. And renal protection, I'm going to leave to the good Dr. Aurora, who's going to be much better at elucidating that. But you put really these two together, and when you have a cardiorenal problem, right, SGLT2s are really wonderful in trying to help. And if you look at the benefits of SGLT2, you can see that here. Hematocrit is there. There may be a little bit of weight loss, but it really is more improved glycemic control and lipolysis, which is doing that. And then those improved ventricular loading conditions that we talked about before. So all of that kind of enters into being a little bit better as far as helping cardiovascular disease. And if we look at this for some of the quote unquote novel mechanisms, these are actually not so novel anymore. Some of these are a little more established. But because we are actually improving some of these things, including adipokine regulation, we're improving some cardiac ions, as well as the myocardial energetics that I spoke about before, we see a lot of these potentials to improve cardiovascular outcomes. And now we're going to see some data as far as what kind of benefit we're seeing, because there are multiple trials, and I tried to put everything on here, and I missed a couple, but suffice to say that really starting relatively recently, if you think about it, right, 2015 is not that long ago. That's when we had the EMPA-REG, and that was the first study that was not even a cardiovascular endpoint study. But we lucked into cardiovascular endpoint and went, wow, this really could be game-changing from a cardiovascular standpoint for a diabetes drug, and got us that first shot to say, maybe we should be thinking about this, and then update all of these things all the way through to, even to preserved ejection fraction. So lots and lots of studies, many hundreds of millions of dollars actually put into these drugs, but a lot of very, very good data, which I'm going to feature in a second here. So I'm going to pause just a little bit and talk about potentially what's happening now as we're starting to see kind of the mix and match. We're seeing this with the GLP-1s and the GIPs, and now we're starting with SGLT2s and SGLT1s. Could there be some additive benefit? Because SGLT1 actually absorbs glucose in the small intestine and helps the reabsorption of some of this nephrotic glucose. And so we may be able to help that glycosuria. Now, just remember that everybody, all the molecules you see over to the left-hand side here, these are selective, not exclusive, right? A very important point, selective, not exclusive. But suffice to say that some of these are pretty far off. And so, but sotagliflozin is the only one that's actually, close enough as far as its selectivity. It's still only 20-fold higher for SGLT2 versus SGLT1 versus the thousands. And so whether or not we do have a little bit of data to show that this may be beneficial, whether or not it's incrementally enough beneficial to make it preferential is not totally clear. But let's take a look at some of the outcomes. So if you looked at major adverse cardiovascular events from the outcomes, right? And if you looked at patients with atherosclerotic disease versus patients with multiple risk factors, overall, there was no significant benefit for those with multiple risk factors. But once you got to the higher risk patients, atherosclerotic cardiovascular disease, we saw about a 14% relative risk improvement, okay? And so choosing your patient becomes really important. You can use it for patients with heart failure, and we're going to see some of those data. But we really should be preferentially using these in the high-risk patients, ideally with some kind of atherosclerotic cardiovascular disease, prior MI, known obstructive coronary disease, peripheral arterial disease, something like that. Those are the patients that we think are really going to benefit more and really fit into more of this 14% versus really kind of a null effect. If you look at some of the outcome trials, what is the driver, which is always the interesting thing. Interestingly, myocardial infarction is there, but it's not, sorry, I should say stroke is, pretty marginal, only at about a 3%, and that did not reach statistical nirvana. So we don't think that there's much benefit. So really the overall benefit, the interesting part of this is that it's myocardial infarction and cardiovascular disease that's really the winner here. That seems to be the driver for these SGLT2s. And so when we see that data you're going to see in a second, as far as cardiovascular events, a lot of it's going to be heart failure, but we do see that this is going to be more coronary disease rather than stroke. If we look at this for hospitalization for heart failure and cardiovascular death, and most of the bigger trials actually use this as an endpoint. I'm using meta-analysis rather than multiple trials just to make things better, to make things easier for us. Again, atherosclerosis seems to benefit. Now you're seeing this significant improvement. You're seeing a 24% improvement in heart failure, cardiovascular death, and a lot of that is driven by hospitalization for heart failure. That's really where we're seeing the benefit in these patients. Multiple risk factors, not so much, barely didn't reach statistical nirvana, but we think that, could be some benefit for heart failure with those particular patients. Now, what about patients with heart failure? Again, because we think that this is going to be a really big driver for these, and it did, and the data really show that this is really kind of the gold ring, the brass ring for us. If you looked at all-cause mortality in patients with heart failure, right? This is all-cause mortality. These are toe tags. This is unequivocal events, right? Unequivocal events. You can see you have a 17% risk reduction in all-cause mortality. Now, if you looked at the trials themselves, you didn't actually see much. DAPA was really the only one that actually reached that. But with an meta-analysis, we are seeing this 17%. So we think that this is probably real. This is consistent with the other diuretic data that we've seen, that in patients with heart failure, if you treat them with diuretics, then patients tend to do better as far as all-cause mortality. They don't have as much, dying from heart failure, arrhythmias, et cetera. If you looked at heart failure hospitalization, it becomes even more pronounced, right? So if we combine these together, you would see even more pronounced. But now you're seeing a 32% risk reduction in heart failure hospitalizations, and that was very consistent with all of these medications. So a lot of the drivers here are the heart failure hospitalizations and heart failure exacerbations, and that's going to translate to your better cardiovascular deaths as well as all-cause death. Now, what about diabetes versus not diabetes, right? And the reason why we see the shift over is because it's a diabetic medication, but is it? The answer is yeah, kind of, right? Yes, it's a diabetic medication, but it does actually serve us well in the heart failure population, even in the non-diabetic population. So if you look at the couple within this particular meta-analysis, it's the most recent meta-analysis that was out for DAPA-HF and as well as EMPEROR reduced, you can see that there's a substantial reduction, 31% relative risk reduction, right, in a heart failure hospitalization in non-diabetics. So the glycosuria is actually really, really quite beneficial. If you apply this to patients that are diabetic, interestingly, the numbers don't change all that much, right? So we are seeing this very consistent benefit. So for those patients with heart failure, SGLT2 has become now the fourth pillar for those patients with reduced ejection fraction, and really kind of the second or third pillar for those patients with preserved ejection fraction. And if we look at cardiovascular death, non-diabetic population, not quite as robust. It did not reach statistical significance, but very statistically significant for patients with diabetes. Now, if we looked at the heart failure type, right, because we generally break this down into 3 different types of heart failure. We have heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and then there's this weird one, this HFrEF, which sounds like somebody was stuttering a little bit, but it's the mildly reduced or moderately reduced ejection fraction. That's that kind of 40 to 55%. It's kind of that middle ground, either going up or going down in general. If you looked at the HFpEF, the less than 40%, those people, really not a whole lot of benefit as far as mortality goes. It really was the HFrEF that we really saw that mortality benefit. Cardiovascular death, it was a little more muddy, but as far as all-cause mortality, really the benefit is within the HFrEF. This one didn't show statistical significance, but we do see from DAPA and some other ones that we are using this a lot. So we are seeing some trends more towards all-cause death as well as cardiovascular death. Once we combine the cardiovascular death and hospitalizations, again, we saw that before for HFpEF and HFrEF. HFrEF was much more profound. For this particular thing, we didn't actually see much benefit once we combine those things, because cardiovascular death was not quite as robust. But we are using this more and more because the new data are showing that actually for HFpEF, we are seeing decreased hospitalizations for heart failure. So in summary, we see really the most benefit in those patients that have cardiovascular disease and heart failure, right? So when you're thinking about SGLT2s for these patients, if they have heart failure, SGLT2 is going to be one of the ones we're going to reach for. If they have significant cardiovascular disease, prior ASCVD, myocardial infarction, stroke plus or minus, peripheral arterial disease, cerebrovascular disease, those patients are the ones that are going to preferentially benefit, and especially when you have diabetes, right? There's reduced hospitalizations for heart failure. It seems like all drugs actually do that. It doesn't matter what SGLT2 you use. Interestingly, no change in stroke, despite some theories that it should. The data are the data. We really don't see much benefit in that, but really the improvement in CV death was more for EMPA as well as DAPA. That's really where we saw it, but it looks like it could possibly be a class effect. Those patients with pre-existing heart failure, specifically the reduced ejection fraction, that's part of the 4 pillars, and those patients should be are really going to benefit. For preserved ejection fraction, we may see some decrease in the hospitalization for heart failure, but maybe not mortality or cardiovascular disease, unless they climb up into those patients that already have ASCVD, right? And so that's where this whole cluster of cardiovascular disease, renal disease, as well as heart failure, that whole cluster, as patients get more and more of those clusters, they become higher risk. So here's what we try to follow. Now, this is completely confusing, right? So what I say is it's kind of like, it's the mind-blowing thing, right? I can't possibly figure this out. So we tried to simplify it a little bit. And these are the ESD guidelines as far as the quote-unquote novel glucose-lowering drugs, right? And then if you have drug-naive patients, in those patients that are ASCVD or high risk for cardiovascular disease, SGLT2 or GLP-1 are recommended, and those are the GLP-1s that are with proven benefit. Otherwise, metformin. Those people are already on metformin. Then again, high risk, those patients should go on SGLT2, and you can see the definitions are down here. Very high risk would be established cardiovascular disease, target organ damage, 3 or more risk factors, or early onset type 1, or greater than 20 years, not 10, 20 years of diabetes. And then as far as drug selection, SGLT2 versus GLP-1, this is my final slide. When we're trying to think about this, right, metformin therapy, and this is maybe been changing a little bit, but if you look at the cardiovascular outcome trials, metformin monotherapy for diabetes was really the basis for all of this. So we'd have to go a little bit far afield if we're not doing metformin first, as far as cardiovascular endpoints go. You can consider either GLP-1 or SGLT2, and it doesn't really matter what the HbA1c target is, right? To pick the right drug in order to get to the right dose, just like statins, right? Pick the right drug, right dose to get to your LDL goal. And if they have atherosclerotic cardiovascular disease or stroke predominance, then maybe a GLP-1 might be better because GLP-1 does have that stroke benefit. If it's heart failure or CKD, then SGLT2 with that proven benefit is probably a better way to go. So that's kind of that simplification, and that's what cardiologists like because we can't think past any of this. This is about the best that we get. So choosing those are very helpful. SGLT2s cardiologists use a lot because they're give and goes. We don't have to worry about it. GLP-1s are more subtle, and so we are uncomfortable doing that. So you're not going to see a lot of GLP-1s coming out of cardiologists, but you see a lot of SGLT2s coming out. And so with that, I will go ahead and move over to the much smarter cohort here, which is Dr. Aurora, unless we have some questions. Do you want to just do the questions at the end? Yeah, okay, we'll do questions at the end. All right, Dr. Aurora, who will correct me for all of my foibles that I just said over the last half an hour. So 9.
Yeah, no, thank you. That was great. So I get to talk about the nephrology side of things because Kelly already did a lot of the mechanistic elements of SGLT2 inhibitors. I'm really going to focus on outcomes, disease management, and then at the end, give some practical advice on how I look at these and how I implement these in clinic. And so one thing that is hard sometimes is to, view the forest from the trees. And this is my view of diabetes, where my goal is really to both slow progression of kidney disease as well as decrease cardiovascular events. And the things in black under that are kind of the surrogates that we use and the ways we do this. And I think it can be really easy when we're seeing patients in clinics to get bogged down in kind of day-to-day glycemic management and blood pressure and albuminuria and all these things. And that's important. But just focusing on, well, why are we doing those things? It's to keep people off dialysis and to keep them free of cardiovascular events. And that's where a lot of these medications have been so beneficial. So one of the cool things about dialysis and nephrology in general now is that the incidence of end-stage kidney disease is actually declining since, kind of the mid 2000s. I'll talk about why that is, and it's just a testament to increased, therapeutic options we have for our patients. If you think about before 2002, we had nothing. We would just watch patients get worse, end up on dialysis or transplant, et cetera. And then it really was in around 2002 that we had approval of renin-angiotensin inhibitors, and specifically angiotensin receptor blockers, ACE inhibitors, for the treatment of diabetic kidney disease. And it came from 2 trials, and I think it's worth giving them their due. So the first one, both published in the New England Journal of Medicine in 2001. The first one was the Renal trial. And what this looked at was taking over 1,500 patients. They randomized them to losartan versus placebo. They had to have both type 2 diabetes and chronic kidney disease to make it into the study. What you can see, and I'm just going to direct you to the bottom left curve here, is that it reduced the incidence of end-stage kidney disease by 28%. Prior to this, we had no therapeutic options for this. And we're going to tip our hat to the Renal trial. The next thing was the IDNT trial, because at that point, if you think about what that trial looked at was an antihypertensive agent versus placebo. And so the thought was, well, maybe it was just the blood pressure control that was driving that improvement in kidney outcomes. And so the follow-up IDNT, what then they said was, well, then let's compare irbesartan as your angiotensin receptor blocker versus amlodipine to achieve similar blood pressure control versus placebo. And you can see on the right here that the relative risk reduction, again, for a primary composite outpoint was the best with the ARB, even better than amlodipine or placebo. The big thing was there's no mortality benefit. So of course we know now that outside of blood pressure control, there's specific benefits to renin-angiotensin aldosterone inhibitors. This one showed that ARBs are particularly beneficial. So again, we're going to tip our hat to these kind of original trials that gave us our first option. The problem is that in this country, as we compare to other countries, we do a poor job of prescribing these agents to people with chronic kidney disease, particularly as they get more severe in terms of stage. So this is the US on the right compared to other countries. And you can just see that both the incidence and prevalence of angiotensin receptor blockers and ACE inhibitors are very poor compared to others. And this is the trend that we need to change, because these medications both have cardiovascular benefit in terms of heart failure benefit, but also they keep people off dialysis. So after those studies came out, it became clear that if you don't have proteinuria, you don't derive any specific kidney benefits outside of blood pressure control related to ACE inhibitors or ARBs. And so this is an important point. If you have patients with kidney disease, doesn't have to be diabetes, any kind of kidney disease, but they have non-proteinuric disease, they have normal UACRs, UPCRs, there's no benefit to ACE inhibitors or angiotensin receptor blockers specifically for the kidney. Though they may need them for their heart, they may need them for blood pressure control, but worth pointing out that there's no added benefit to the kidney in the absence of proteinuria. What happened after 2002 is that nephrology went into this really dark period. These were the dark ages between 2002 and 2015. All these studies flashing across your screen were negative. So we tried everything in diabetes to prevent end-stage kidney disease. Everything was negative. You can talk to any nephrologists that were practicing at the time. Everyone was depressed. They were becoming alcoholics because nothing was working despite all these trials. And then in 2015, Kelly mentioned it, there was this beacon of hope when the EMPA-REG trial came out. This was specifically a cardiovascular outcomes trial. As he mentioned, it was almost a mistake. This was done because the FDA had mandated that any anti-glycemic drug show cardiovascular safety. And not only did it show safety, it showed these profound benefits in terms of cardiovascular outcomes and mortality. In the secondary outcomes of this trial, it showed kidney benefit, but we had been burned before. It's hard to look purely at cardiovascular outcomes and look at the secondary outcomes of those trials and derive benefit for the kidney and really utilize that. So we kind of held our breath a little bit. But after that, there was an explosion of trials that I think Kelly already showed. And I'll direct you to 2019. And I still remember where I was when Vlado Perkovich stood up at the World Congress of Nephrology and presented results of the Credence trial, which was the first trial looking primarily at a kidney outcome with canagliflozin. And it was, of course, positive. And I think every nephrologist was high-fiving and popping champagne, and because we finally had another agent that was effective for our patients. And what's happened since then is that these have become the most powerful cardiorenal medications that we have. And as Kelly alluded to, we've kind of taken control of this from the endocrinologist because it really has this pesky side effect of lowering blood sugar. It's not the primary reason to use these medications. It really is the cardiac protection and the renal protection. In the KDIGO 2022 CKD DKD guidelines, this became the only 1A recommendation. So it was a little bit of controversy, but this is even more than angiotensin blockers and ACE inhibitors. And just a little note of this, though, this was in 2022. Just in the 2 years since this was published, we've had a lot more data with non-steroidal mineralocorticoid receptor antagonists, with GLP-1 agonists, and specifically regarding kidney benefit. So I think some of these agents are going to get promoted in the future, and we're going to see more of these. And I think DKD, or diabetic kidney disease, is moving towards a guideline-directed therapy model similar to what heart failure, at least with reduced ejection fraction, has. And so I think this is rapidly changing. So how low can you go when we're talking about what GFR can you actually initiate therapy? And what's worth pointing out is on the left, these are the GFRs that continue to get lower with the studies that come out on the right. And so currently, you're approved to start these medications if your eGFR is 20 or greater. I will tell you, in our cardiorenal clinic here, we start these under that all the time. I can't officially tell you to do that because that's the approval is for 20 or greater. The point there is that it's not that we don't think they're effective at GFRs lower in this. It's just that they haven't been studied to date. And that's changing with ongoing studies. But currently, if you have a GFR 20 or greater, you are okay to go ahead and start an SGLT2 inhibitor. A point about the glycemic benefit, that completely goes away below an eGFR of around 45. And so even though it's a modest anti-glycemic agent, even at higher GFRs, it really kind of abolishes below a GFR of 40. The data by Will Harrington here, and this was unpublished data, so I'm just going to give a shout out to him for supplying it, that in these studies, if you snuck into that during that run-in period with an eGFR less than 20, that's the top line there, you still did see the same relative risk reduction of those primary kidney events, even compared to the GFRs that were higher. The reason it doesn't meet statistical significance is they're small numbers. You're not going to get the number of events to make it statistically significant, but you can see with that hazard ratio that the relative risk reduction appears to be the same. Currently, the recommendation is you initiate these things at whatever GFR, and then once your GFR gets below 20, you continue those medications until a patient is on dialysis. Okay, that's the current recommendation. I do think that's going to change in the relative near future. If you look at the DAPA-CKD trial, there was a number of patients that actually continued dapagliflozin at dialysis initiation. In that study, dapagliflozin was associated with a relative risk reduction for mortality by 21% compared to placebo. We have nothing in dialysis that improves mortality outside of a kidney transplant. And so this is really reassuring data. Again, it's a subgroup. And so we're awaiting other studies. The largest of that on the right is the renal life cycles trial. This is not only looking at dialysis patients, but also patients with more advanced chronic kidney disease. And so, I think there's going to be more data in that population coming in the next couple of years. Here is data in terms of, progression of kidney disease or death from a cardiovascular cause. And what's important here is that it appears to work even in the absence of proteinuria. And so, one of the things we mentioned with angiotensin receptor blockers is that though that class of medications, they're great, they keep people off dialysis, but they had no mortality benefit. Here, or excuse me, they didn't work in the absence of proteinuria. Here it appears they do. And people that are looking at the UACR less than 30 are going to think I'm crazy because your hazard ratio is 1, showing no benefit. But remember, if you have no proteinuria, you're not going to progress as quickly. Those are very, very slow progressors to end-stage kidney disease. And so if you have studies like EMPA-KIDNEY, which enrolled patients without proteinuria, and you stop it early, right? That was stopped before the 3-year mark because of benefit. You're not allowing enough time for those outcomes to take place. And so when you look at eGFR slope, which is an FDA accepted surrogate for kidney disease showing benefit, you can see that if you are on empagliflozin, so on the top, you had benefit in terms of long-term slope with a 25% risk reduction. And similarly, you had benefit with total slope. And so it does appear that these are beneficial even outside of proteinuria. Now, again, those patients, it's more of a discussion because although the relative risk reduction is high, the absolute risk reduction may be low because, again, they just don't progress as quickly. They don't have as much cardiovascular disease because that albuminuria really predicts the initiation of cardiovascular disease. And so those are shown there. Here is kidney disease progression overall. And so these are patients with diabetes on the top, without diabetes on the bottom. And I know this is a diabetes echo, so we'll just point out that the relative risk reduction for kidney disease progression was 28% in the cohort with diabetes. Worth pointing out for all of you that are taking care of patients with chronic kidney disease without diabetes, that the relative risk reduction was almost identical when you didn't have diabetes. So these agents do work with or without diabetes pretty much with the same equivalence. Here is outcomes in terms of cardiovascular death and all-cause mortality. And so if you look at a meta-analysis of all these trials, there was a 14% risk reduction for cardiovascular death and 11% relative risk reduction for all-cause mortality. And again, this distinguishes these particular agents from the angiotensin receptor blockers, which had no mortality benefit in those 2 large trials. So if you were just thinking about comparing SGLT2 inhibitors with angiotensin receptor blockers, the effect on end-stage kidney disease is very similar. Effect on hospitalization is very similar. Even composite kidney outcomes are more or less similar. I think the distinguishing thing is the effect of mortality that SGLT2 inhibitors have, as well as that impact on non-proteinuric CKD as well. I was really annoyed. There was this New England Journal kind of editorial that suggested that because since the trials included a requisite that patients were on the quote unquote highest dose of RAS inhibitors prior to entering a trial with SGLT2 inhibitors, that maybe they don't work if you don't have an ACE inhibitor or an angiotensin receptor blocker on board. That's totally untrue. We've collected enough patients now that weren't able to tolerate a RAS inhibitor, and so we're entered into the trials without one. And so we have over 5,000 patients. And so of those, you can see the relative risk reduction with or without the angiotensin receptor blocker or ACE inhibitor were the same, but the absolute reduction is going to be higher if you're on both therapies, right? These work synergistically, whereas the SGLT2 inhibitor works primarily on your afferent arteriole, the blood vessel going to the kidney. Your RAS inhibitors work on your efferent arteriole, the blood vessel leaving the kidney. So they have this synergistic effect of decreasing single nephron GFR, decreasing the workload of the kidney. But what that means is if you have a patient that cannot tolerate an ACE or an ARB for whatever reason, that doesn't exclude them from an SGLT2 inhibitor. Here's the classic GFR slope. And so what this shows is that you're going to have a decline in GFR when you initiate these agents in many patients. And I can't tell you the number of patients that I see that where their SGLT2 inhibitor is discontinued because their creatinine goes up or their GFR goes down by some, a moderate amount, just to show that that's an expected effect and that curve is going to cross over and show benefit. I picked EMPA-KIDNEY in this case because it was the longest. It took 18 months to cross over because you did have those patients with non-proteinuric kidney disease. All the other trials showed about a 12-month crossover, so don't be dissuaded by these rises in creatinine. And we've seen that with multiple studies. So this is the EMPA-REG trial. About 30% of the population had a greater than 10% drop in eGFR. About 0.5% had a 30% drop or more. The risk factors were lower GFRs at the time of initiation or concomitant diuretic use. What you're seeing in this graph is that whether you were an eGFR dipper, non-dipper, or intermediate dipper, meaning the degree of decline in GFR when starting these agents, it had the same amount of benefit. It didn't predict response based on that initial decline in GFR. Similarly, if you look at outcomes, this is the DAPA-CKD trial. So you have dapagliflozin in blue, placebo in red, and then your eGFR outcomes on the y-axis here. Irregardless of what your eGFR did, it could have gone up by 30%, down by 30%, something in the middle. If you got randomized to dapagliflozin, you still did better than placebo at every level of GFR change in terms of your overall kidney outcomes. If we borrow from the heart failure literature, so this was an interesting observation here in the DAPA-HF trial, which was dapagliflozin versus placebo in patients with heart failure, they saw similar risk factors for eGFR decline, similar degrees of eGFR decline. But if you look at dapagliflozin in blue versus placebo in red here, a decrease in GFR up to 30% not only showed significant benefit compared to placebo in terms of the heart failure outcomes, it was actually predictive. In fact, if you didn't have that GFR dip in that trial, your incidence of heart failure events was no different than placebo. And so yet another reason not to stop these agents with, rises in GFR. We'll typically always tolerate 30% decreases in GFR, sometimes up to 50%, just depends on, what might be driving that. The same is true, just an aside, for ACE inhibitors or angiotensin receptor blockers. And I wanted to mention this because we see a similar thing with these agents. So this is, again, borrowing from the heart failure literature. This was the SOLVED trial, which looked at enalapril versus placebo. And I'm just going to direct you to the top left here. This is looking at all-cause mortality, enalapril on that bottom curve, placebo on the upper curve. Even if your GFR went down by 40%, you still had better outcomes than placebo. And so, I think we all have in our mind this 30% number, just to point out it's a little bit made up based on expert opinion. So it doesn't mean don't go looking for causes of that, but just showing you that if you're inducing that with a medication that has mortality benefit, you really want to try to keep them on that medication. There was initially this thought that, hey, could SGLT2 inhibitors be causing acute kidney injury because of that GFR drop? We now know, again, a meta-analysis here that's showing not only is it not acute kidney injury, it's actually protective for acute kidney injury. It reduces the incidence by 23%, probably because of its impact on ischemia reperfusion injury. So now there's studies ongoing looking at actually giving this to patients in the hospital, et cetera. So it's not a true acute kidney injury. And in the vast majority of the cases, there's some case reports from osmotic nephropathy. I think there was 2 that I've seen in the entire literature that we have. There are safety outcomes to consider. There was this question in the chat about urinary tract infections. Just pointing out the risk of actual bacterial UTIs is extraordinarily low. So you're looking at over 40,000 patients here. The risk of bacterial urinary tract infections with SGLT2 inhibitors was very, very low. The relative risk was 8% in terms of a bacterial UTI. So it doesn't mean it doesn't happen. It just means it's extraordinarily rare. Out of those, there was no increased incidence of serious urinary tract infections. The main risk that we see commonly are mycotic genital infections. And I know there's some questions. So just to go into those, there is this 2 to 4% increase, or 2 to 4-fold increase, in genital mycotic infections, generally pretty easily treated with topical antifungals. Occasionally, you'll have to give somebody a one-time oral dose of fluconazole. You can generally treat through with the drug, and it rarely leads to permanent drug cessation, but certainly happens. And I have patients just call our clinic if they have concerns about this. The other risk is this concept of euglycemic acidosis because of its impact on the metabolic changes that you see. Just to point out that this is almost exclusively seen in patients with diabetes, but that risk is there. In all the trials, there was one patient with non-diabetic kidney disease that developed euglycemic ketoacidosis, and that was because they had been treated for 7 weeks in the hospital with a serious illness, and their SGLT2 inhibitor had been continued. the point about the euglycemic ketoacidosis is that there's almost always a cause you can point to. And so, for example, in the Canvas trial, they showed that the patients that developed ketoacidosis, 83% of those were sick and had some precipitating event. And so the way I kind of mitigate this risk, I know there's controversy over the, sick day rules and stuff like that. My thought is these are long-term beneficial medications. I just have them hold it if they're sick, if they can't take keto intake, if they have diarrhea, if they're risk for volume depletion, etc. If they're going to have a surgery where they need to be NPO, I hold it for 5 days. I know the recommendation is 3 days. There are case reports for people developing this up to 7 days. And so my practice is to do 5 days. We can hear from others in terms of, what they do in practice, but I just have a dot phrase in Epic. And whenever I prescribe these, I just give them these and I say, hey, just put this on your fridge. Just remember when to hold these medications. And I've actually never had a case of euglycemic decay or euglycemic ketoacidosis to this point. I use these a lot. And in my last few slides, I just want to show you, the power of these drugs in terms of dialysis. So at the top, you're looking at a mathematical model of looking at starting these agents at a GFR of 85 versus 20, looking at GFR slope. So what you can see is that if I start an SGLT2 inhibitor with somebody's GFR is 85, so meaning they have proteinuric kidney disease, their GFR is preserved, in this model, I'm delaying end-stage kidney disease by over 25 years. Okay, if I started at an eGFR of 20, which is currently the lowest threshold for initiation, I'm delaying dialysis by 2 years. And so that's still helpful. If I could have 2 years off dialysis, I would want that. But just showing that earlier initiation, you're getting that longer term benefit by keeping people off dialysis for longer. On the bottom, all you're looking at is the same thing, but the number of hemodialysis sessions avoided per patient, depending on where you start in terms of their eGFR. The other point is if you do happen to start it, you really want to try to avoid stopping it. So this is a large study of a VA population with chronic kidney disease stages 3 and 4. And what they looked at was if you had an incident prescription of both SGLT2 inhibitor or a GLP-1 receptor agonist, what happened if you discontinued that medication after starting? And what you can see is that if you, on the left, bottom left here, if you started an SGLT2 inhibitor then stopped it, your odds ratio for death went up 67%. Your risk of heart failure hospitalization went up 26%. You had a similar issues with GLP-1 agonists where your risk of death went up almost twofold and your myocardial infarction risk went up 23%. So if you do start it, you really want to continue it as much as possible. This is newer data. This is long-term data that was published in the New England Journal of Medicine earlier this year, looking at long-term results of the EMPA kidney trial. And what this showed was that in the top graph, there was this active trial period where 90% of people randomized to empagliflozin were on the drug. 2% of patients in placebo were on the drug because of crossover. After they stopped the trial, they didn't supply the study drug anymore. So it was up to individual treating clinicians to decide if they wanted to start it. It was about 40% in each arm that got the SGLT2 inhibitor. On the bottom, what you're looking at is if you stopped your empagliflozin after being on it for that 2-year period, your protection from overall outcomes was present for that first year, where your relative risk reduction was 24% from all outcomes. But that disappeared after that first year. And in fact, it was really the first 6 months that provided the most benefit. So at the tail end, if you stop it, you maintain some benefit for a year, but then disappears after that first year. And then you're no better than placebo if you stop these agents. So just in conclusion, one thing that from practical advice here, remember the studies excluded anybody with an A1C greater than 12% because of the profound osmotic diuresis you're going to get. In clinic, I usually wait until their A1C is less than 10% because I don't want people to have this powerful diuresis. I don't want them to get turned off by the med because of the long-term benefits. Remember, they do potentiate the loop diuretic effect by around 20%, meaning if I have somebody in heart failure clinic, if they're euvolemic, I may decrease their loop diuretic by about that amount temporarily, and then we can always go back up. That initial diuresis usually lasts about 2 weeks or so. And then really we just need to get these drugs into more people because of the profound benefits they have. The other things, remember, they're not new. I know we're doing these sessions, but they've been out for nearly a decade now. And so patients don't like to be on a quote unquote new medication oftentimes. And so I don't introduce them that way. The other thing, the molecule initially came from apple bark, and for whatever reason, particularly in the Pacific Northwest, this will resonate with people and maybe make them more likely to take it. And again, based on that data, if you start it, you really want to take all precautions to continuing it because of the lack of benefit and even harm with stopping it. So this is what I was mentioning. I think, we're going to get to a point that similar to Kelly and heart failure with reduced ejection fraction, we're seeing a similar trend with diabetic kidney disease, where we're going to have these 4 pillars of therapy. And I think that is coming in the near future. So I am going to stop there and I'll turn it back over to Nicole.
Thank you, Nyan. That was a great presentation. And I love that little tidbit about the apple bark. I think it would resonate with people. And I'm going to actually turn it over to our case presenter, and she's going to start her great case presentation. So take it away, Annika.
My name's Annika Barnett. I'm a PA over at CMAR. This patient has been a patient at the clinic for, I think, about 10 years, but I've only met him a couple of times. So he had previously controlled type 2 diabetes on a variety of oral medications, but most recently it has been above 9%. He previously was injecting glargine and was at goal, but he self-discontinued it in 2021. He said he was tired of injecting and he was getting bruises and he didn't like that. We're thinking we had talked about starting a GLP-1, but trying to figure out what the next step is. So scrolling down here, this is some of his past medical history. His BMI is 28.5, dyslipidemia. He's a former smoker, only 3 pack years. He smoked for a very 22 years, but not very much. And then microalbuminuria. These are the medicines, his current regimen. So he's taking metformin BID 1,000 milligrams. He's taking glipizide 5 milligrams twice a day, sitagliptin 100, lisinopril 2.5, and atorvastatin 40. Something that as I was digging into his chart a little bit more, he actually was on Jardiance. So this could maybe be a little bit more of a conversation. It's a little bit unclear when and why that stopped, but I'm sure we'll get into that. And then maybe we can talk about the stopping and restarting issues there. No known allergies, no family history that we know of here. He works like a custodian at the university. He does a lot of walking at his job. He actually works in the stadium, so he's up and down and walking a bunch of stairs. And something to note is his current shift is 3 a.m. to 12 p.m. So that kind of messes with timing for food and medications. Here are his vitals. He's a smaller gentleman at 4'11". He is 141 pounds, and his normotensive. And the glucose was random not fasting 245. The most recent A1C was 9.3, creatinine 0.73, cholesterol 134, the LDL of 75, HDL of 27, and triglycerides 163, and 43 on the microalbumin creatinine ratio most recently, and his LFTs were 28 and 24. Just looking at the A1Cs over the past year, they've been steadily creeping up. Like I said, he was previously at goal, but this past year they've been going up. Each time there's been some continued discussion about adding or adjusting medications, and he is pretty active. So he runs now, it's I think 3 times a week for 50 minutes on the treadmill, and he has been able to get back to goal by increasing this amount of exercise. So each time he's been trying to say, okay, I want to work on my exercise and try to bring it down that way. And he's up to date on his retina. It was normal, foot exam normal. And his last health ed, we do have a health educator and nutrition at my clinic, but he hasn't done health ed in a long time and nutrition since 2020. He is Spanish speaking. He doesn't want to inject. Those are some barriers. Another barrier when I was digging into this is it appears there was a while where he didn't have a phone connected. There was some issues with transportation getting to the clinic, And then there was some changing in insurances. Right now he does have Regents, but previously this was a challenge with medications and cost. So like I said, his current shift is 3 a.m. to 12 p.m. So he usually has breakfast. He does a salad and coffee with creamer that he brings. And then his lunch is bigger when he gets home. That's his big meal for the day. He does chicken, rice, beans, tostados, fruit, and vegetables. He previously was doing more tortillas and burritos, but he's limiting these to just the weekends now. When I was digging into his chart before this, I was seeing that his daughter, who he lives with and does a lot of the cooking, she sells tacos and burritos. And so she's always cooking. And previously this was a challenge for him to avoid, because I'm sure it smells delicious all the time. So, and then he goes to bed pretty early since he starts his shift at 3 a.m. I think I mentioned already that he was active, but he doesn't drink alcohol, soda, or any energy drinks. Occasionally it says that he has some Gatorade, but it's unclear how often that is. And yeah, the active, when he does do his runs, it's about 2 to 3 times a week, but periodically he'll go through phases where he's not doing as much of that. So just trying to figure out where to go from here with the A1C of 9.3. And yeah, I think that's all I have on here.
Thank you, Annika. This is Savita Subramanian. I think most of you know me. I've been on the calls a few times. Sorry, I joined a little late. I will start off, Annika, with this gentleman's microalbuminuria. Is that he has very mild early microalbuminuria. Have you had labs before where he has had albuminuria that you've noticed? And has it remained stable? Any input on that?
Yeah, so I saw it was first documented in his chart in 2018, but I don't see the lab value from then. And then it was actually normal since then. And then this is the first time since then that it's been elevated.
Okay, so he's had this mild albuminuria for at least 6 years, is what it sounds like. At least whenever it's checked, it's been positive, right? Okay.
Oh, he's had some that have been negative as well.
Negative. Okay. So from what you're saying, so he had positivity, then he was negative, then now he's positive again?
Yeah, exactly.
Okay. There's Dr. Aurora's rationale for an SGLT2 inhibitor right there. Okay. So, and so with these folks who work these swing shifts or graveyard shifts, when does he go to bed? Do you have a sense of what his schedule is like and when he takes his meds? And you did share that he has a breakfast and then a large lunch. So that would probably technically, maybe that would be a dinner-ish meal for the average person who doesn't work this kind of shift.
Yeah, I do have a kind of what he was doing for his schedule. So he was taking metformin, Januvia, and glipizide in the morning with his mid-morning meal that he has at work. And then he takes the metformin, glipizide, atorvastatin, and lisinopril in the PM with his late lunch dinner. I'm not exactly sure what time bedtime is for him. 3 a.m. start, so I'm hoping he gets to bed early.
Okay, great. Yeah, thank you for that. So the reason why I bring that up is it's very important to know an individual's schedule, especially if they're on complex regimens, and how are they taking their medications? Are they skipping it because of their work schedule? Very important to know what their sleep schedule is, etc. So here's a summary. Are there any other questions on this patient, on just general questions?
Yeah, I just had a similar kind of, concern about sleep. Is there any concern about sleep apnea, or have you done a stopping in the past for him?
I haven't personally done that, and I didn't see anything in his chart regarding that. Yes, good question though.
Is he hypertensive?
No, he's always been normotensive. I think it was 127 most recently, over 70, I think.
When was his last, you said remote smoking. How long ago did he stop? And do you know how many pack years?
Yeah, he stopped at in his 30s. I think it only added up to 3 pack years.
Okay, thanks.
It's like a couple cigarettes a day from 12 to 30 something.
So here's a summary of our gentleman, 60-year-old, type 2 diabetes, maybe dyslipidemia, microalbuminuria, and his BMI is 28.5, and he's insured with Regents. He's a janitor working swing shift. He doesn't drink alcoholic beverages. I'm going to call him a non-smoker because it's over 30 years since he has smoked. Presumably, he's divorced. Sounds like he lives with his daughter, so he's housed. Maybe some transportation issues, possibly, or maybe not. And his most recent A1C, as provided by Annika, A1C is 9.3%. His LDL is 75 on high-intensity atorvastatin. His triglycerides were 163. And I put the A1C trend here. As you can see, in the last year or so, his A1C has gradually risen. So this will be the main highlight of this case summary, and this is going to be more of a discussion. So the two barriers that Annika, as his clinician, has raised are, his hesitancy to take injections. He was on glargine before, and he self-discontinued. Maybe his timing of injections, it's hard to know why, but he's discontinued his daily injections, and sounds like maybe there's some hesitancy in taking maybe even weekly injections, unclear. And I showed you his A1C progression. So there has been progression of his diabetes. And actually, I'm not sure how many years of diabetes he has, Annika. Do you know how many years he has been diagnosed with diabetes? Has it been at least 10 years? You said
Yeah,
he's
the
clinic for 10
first
years.
documentation I saw was 2015. So
okay, so 9 to 10 years of diabetes. Yeah. Okay, thank you. So the concerns are the rising A1C on 3 oral agents. He's on metformin, glipizide, sulfonylurea, and he's on a DPP4 inhibitor. So what can we do here? Are there other oral agents that we could add? What medication should be adjusted if we added? How can we deal with the situation where we want to help him? Because he has progression of his diabetes and we want to avoid therapy inertia. But the first question I want to ask is, and this is in line with what Dr. Earhart always talks about, you always want to think, so this is a gentleman with a BMI of 28. He's had maybe 10 years of diabetes. He's on the overweight side, not obese, very active, but he's had diabetes progression. So what kind of diabetes does he have? He probably is, he's behaving like an individual with type 2 diabetes, but again, this is in line with Dr. Earhart suggestion. So if you feel like something's not fitting the picture, you always want to think outside the box and make sure this individual does not have autoimmunity. Doesn't look like it. Looks like he's been pretty stable in his weight. This is most likely diabetes progression, type 2 diabetes progression, and I'll show you in the next slide or so. But if there's some alarm bells that go off in your head, don't have a low threshold to check for autoimmunity. Injection hesitancy, how are we going to deal with this? So patient factors are very important. He self-discontinued previously. Maybe there are cultural aspects here. Maybe there's a perception of failure. Maybe it's his daily schedule, working as a janitor and the late shift. Maybe he is not able to take his injections regularly. Maybe so the adherence is an issue. And, for some folks, taking an injection could mean social rejection, meaning they have a very robust social life and they are out and they don't want to take a shot when they're out and about. So it's important to explore and maybe kind of dig a little bit into why he stopped his, it looks like he was also on empagliflozin before. So why did he stop that medication? Was it a cost issue, or why did he stop his glargine? I think peeling the layers of the onion a little bit is going to be important in this gentleman's case. And diabetes progression, as I've mentioned before, is very important to know. So in all the studies that have been done, the landmark study for type 2 diabetes being the UKPDS in the late 90s now, very old by average standards. What this study showed is, so they had 2 arms, one with very intense diabetes management with A1C under 7, and the conventional arm, that's the blue dots here. But with time, as you can see the years here on the x-axis, even in the intensive control group, the A1C started to creep up at about 6 to 7 years. So there's deterioration in glycemic control in everyone, however intense you try to manage their diabetes. And the reason for this is because at the time of diagnosis of diabetes, if you use this pink dot here in the middle at the time of diagnosis, where an individual with type 2 diabetes is starting, there's only 50% of beta cell function here already. And then from then onwards, only downwards. So with time and the years here at the time and years in the x-axis again. And so, with time, beta cell function will go down. It almost never, it usually doesn't go down to 0, but the percentage does drop quite a bit. And if you extrapolate it by years 8 to 10 after diagnosis of diabetes, many people will need insulin therapy. But again, this is all old data. The trajectory of diabetes is changing now with all the new medications you've heard about, but this is something to keep in mind. So this is what we call diabetes progression. And the reason why I'm highlighting this is because this gentleman said he wants to take care of this with diet and exercise, and he's running, and his A1C is going in the wrong direction. So keep that in mind, because this is very important to educate your patient that this is not a failure, not an individual's failure that they didn't take care of themselves, but this is actually progression of diabetes. And how I explain it to patients is usually this is your pancreas getting older. So this is a 60-year-old individual. So, and he probably has genetics, meaning he probably has a family history. Maybe, we don't know. I think Annika said there's no family history, but it's possible his ethnic heritage is very in line with people with lots of family history of diabetes. So this is something I think it's very helpful for patients to hear that this is not a personal failure, and going on an injectable is not a failure of that individual. So this counseling is actually very important to get your patients to meet you where you're at. Again, this is, I'll go through this very quickly. This is monotherapy. So people who are, and this doesn't apply to our patient here, but I just wanted to point out that whether you've been on metformin or sulfonylurea monotherapy, by 3 years of being on metformin or sulfonylurea, only 44 or 50% will have an A1C under 7. So needing more therapy is part of the deal with diabetes. So really, this is just the disease trajectory. So what can you do for someone who is hesitant? So again, we have to meet the patient where they're at. This individual is insured. So one option for an oral agent is an oral GLP-1, and we have Rybelsus or oral semaglutide. It's the only orally available GLP-1 receptor agonist for now. There are several in development, but nothing is available besides oral semaglutide. It's formulated specifically so that it is absorbed only from the stomach. The drug is released in an empty stomach. It's coated with this absorption enhancer called SNAC, so that when it gets into the stomach, it is protected from proteolytic degradation. Then eventually the drug is released where it should be. I think it's in the intestine, and so it gets absorbed. So you have to take it very specifically, which I'll show you in the next section. But it has been shown, it doesn't have a cardiovascular benefit, but it is safe, meaning it's cardiovascular neutral. There's no negative signals with these agents. And how do you take it? You have to take it on an empty stomach with just a little bit of water without chewing or crushing the tablet, and you cannot take it with anything else. You start with 3 milligrams, and then you increase it after a month to 7 milligrams here. And then if you need more glycemic reduction, you can increase it to 14 milligrams. So this is an option, and he's got Regents. It is tier 2 on Regents for most Regents insurance plans, assuming he's Regents uniform if he works for the university, and he works at the stadium is what I heard. So if you go on an oral GLP-1 receptor agonist, you should stop the sitagliptin because it's duplicative therapy. The DPP-4 is a weaker agent, works on the same pathway. It prevents your endogenous GLP-1 from breaking down, but instead you're using an oral GLP-1. So you want to just use that. So I will stop here, and I'm gonna call on Laura and ask her, what is the weight benefit of oral semaglutide? Is there a weight benefit at all, Laura?
There's definitely a weight benefit, but it's not as much as the patient would get, for example, with the injectable semaglutide. So, and I guess, thinking just about this patient's hesitancy about GLP-1, I guess I wonder what his weight trend has been like, because I think there is some fear to, even in my own father who has diabetes, he didn't want to, go on something and he lose more weight. Like he was already losing weight as he was aging, losing muscle. So I wonder what the weight trend is like, and if that might be a fear for being on these medications. But there is some weight loss. It's just not as much as with one of the injectables.
So I am going to call on Nicole, Dr. Earhart. She corrected me over text message. So do you want to share what you just shared with me on oral semaglutide, Nicole?
Yeah, no problem. So, what's great is our evolving research and literature. And just a few weeks ago, as we mentioned earlier, when we were talking about GLP-1 receptor agonists, the oral semaglutide now does have a cardiac benefit shown through the SOUL trial. So, that's great. And, I think the hard part of this medication is the precision you need to do to take it. With only you were going to talk about that with 4 ounces of water and just when you get up and not within a certain time period with food. But I think the benefit is it's a once a day medication. And you can see he's on twice a day medications. We can easily simplify all his medications to extended release and make them once a day. And that may be along with that higher efficacy from the GLP-1 receptor agonist, the key, because even just reducing his pill burden and making it once a day, I think in his mind will be a big support to this patient. So.
Yeah, and Dr. Branch points out that DPP-4 inhibitors like sitagliptin that this gentleman's on does not have any cardiovascular benefit. They're weight neutral, and has not been any data that shows that they're beneficial from a cardiovascular standpoint or a kidney disease standpoint for that matter. So yeah, the DPP-4 inhibitors are just a whole lot of buck for not much bang, I would say. So, but they do have a role to play in people. I mean, like this gentleman who is hesitant to take all medications. But the trial, the CVOT trial that Dr. Erhard mentioned too is a SOUL trial, SOUL. I have full disclosure, I haven't read it because I don't use a lot of oral GLP-1s, but I would encourage you to go look at it. Other medications that we could add. So this gentleman was on an SGLT2 inhibitor previously, so it's unclear why he went off. As Dr. Arora pointed out in his talk, these aren't that great A1C reducing drugs, but his A1C is 9. You can get a 0.5% A1C reduction. He has microalbuminuria, so he will derive some benefit from these medications. So that is something I would encourage you to look into and see why was it a cost issue. But I think on his current insurance plan, it will be covered. So I think that is an option. And you will get modest weight reduction. Any thoughts on pioglitazone? I gave the pioglitazone talk, so I'm obviously biased, but thoughts on pioglitazone?
I think if he really wants to avoid injectables, and this is after you show him an injectable and you need another add-on, I would try to support him not starting insulin if possible. But in this particular case, I'm not sure if I would. I might, that being said, you could replace the sulfonylurea with the pioglitazone as long as he doesn't have leg swelling, because I do worry as well that this person is potentially holding medication with when he's more active, even though he doesn't love to share that with his provider or his doctor, right? So it wouldn't be a bad thing to do an SGLT2 inhibitor, metformin, pioglitazone, and start with those things again, all once a day medications, and just see that as a starting spot. Especially if you could get him to check his blood sugar maybe once a day, alternating, since he's not been doing that either. Although the first thing I asked myself is, do I believe that A1C? He had the random glucose of 245. So yes, he's actually the one person I might do a finger stick in the clinic just to look at a random glucose as well. So I had, then you have those 3 data points. But I always am a person who wants to move forward with therapy and make changes as long as I'm confident, and that random glucose of 245 made me more confident about that A1C of 9, because that was my other question is, do we believe the A1C? And I think we do. So.
Great. So I think, we're kind of running over here, but the behavior modification tools, Dr. Erhard asked me to put a thing or two on smoking. I'll call upon Dr. Branch to give us his thoughts on, is Kelly still on? Maybe he's not. Oh, you are.
No, I'm still here.
Why don't you give us your spiel on smoking and what you tell your patients?
Yeah. So I'll tell you, obviously I like to use a little bit of humor when I'm going to patients. So if it's a male, I'll say, the only thing I can do to decrease your risk more than stopping smoking is to make you a woman, right? So they kind of chuckle a little bit at that, but that's true. It's actually an equivalent lowering. There's nothing more that's going to lower your risk that I can do. I can't put any pill. I can't, lifestyle modification, sure, Mediterranean diet, maybe that's more, but smoking is the key for us from cardiovascular disease. And that's the bad stuff. Myocardial infarction, stroke, peripheral arterial disease, things that are really driving. So get them to stop smoking. Tell them on average it takes 7 times to stop. That means it takes 1 time for somebody, 20 times for somebody. Just keep hopping back on the wagon. As far as risk goes, if you stop for more than 3 months, your risk goes down substantially. There are data to show that it's equivalent to actually never smoking. We think that that's probably wrong with longer term data, but we go to a new set point, right? So you've caused some atherosclerotic disease with smoking, but you're not going to increase unless you go back and you continue to smoke. So stopping is the key. Whatever your risk is, we can handle that with medication and lifestyle modification. So.
Awesome. Thank you, Kelly. And I just wanted to quickly point out that behavior modification tools like using a personal continuous glucose monitor can sometimes help some people. Maybe it's not this individual, but they're always available and can be offered. In someone who's not on insulin, it may be hard to get it covered, but an occasional OTC CGM, such as the Dexcom Stelo or the Libre Lingo, can be an option, but I won't go into that in too much detail. But to summarize, I mean, pretty much the key points I think in this gentleman are that, diabetes progression is real. It does happen in many people. If your clinical picture doesn't fit, or, if you feel like something's not right, make sure you rule out other causes of diabetes. I think exploring his reasons for injection hesitancy are going to be important, and you have all these offerings right now. But I think preparing him for the fact that injectables are part of injectable GLP-1s, especially, are part of modern diabetes management. I think coaching him and then eventually getting him to where we want him to be. It may take a while. Oh, he may never get there, but eventually, maybe he will. So I will stop with that. And I guess I'd never called on Dr. Aurora. Dr. Aurora, do you have any thoughts on this gentleman and any additional thoughts on his management?
No, I was unnecessary here. I think, if he didn't need the glycemic control and all you were seeing was this, modest amounts of albuminuria, I know we like SGLT2 inhibitors like you talked about. Honestly, I would have just been increasing his lisinopril. We target less than 120 for a blood pressure, and we've seen that even with patients with diabetes, they benefit with that more intensive blood pressure control. And so, your absolute risk reduction with an SGLT2 inhibitor, just purely from a kidney standpoint, would be relatively low. So I would be just increasing that lisinopril dose.
Thank you, Nayan. And one last question for Dr. Montour. Do you think his eating pattern is consistent with or somewhat similar to intermittent fasting? He eats like maybe a small breakfast and then maybe a large lunch, and that's all he eats, or that's what he reports? Would this be a version of intermittent fasting? And what are there any benefits to that kind of eating pattern with his diabetes?
Yeah, so it does sound like potentially, again, we don't know really when he goes to sleep specifically and how many hours of sleep. So it could generally, like 14, 16 hours would be a typical regimen. But yeah, there can definitely be benefit for, it can reduce insulin resistance and can help with improving leptin sensitivity. So it could be a tool. I don't necessarily recommend it a lot necessarily for long-term weight management, because whatever regimen they're doing for lifestyle needs to be sustainable. I guess if that is a sustainable way that he can eat forever, then I think it could be beneficial. But I would be more in line with recommending balanced diet, eating regular meals with protein. But if fasting works for this patient, it could be beneficial.
Thank you, Laura. All right, well, that's all I got. Yeah.
Thank you, Savitha. And again, I think you were great at highlighting and pulling everyone together about individualizing for this patient. And that's, the resounding thing we hear every week with our cases. It's individualizing and really knowing the patient so we can best support them living with diabetes. And hopefully we gave our case presenter some food for thought. And so we'll just say this ends session 7 of the Cardiometabolic Echo. Thank you all for attending.